as much as you give the GnRH and LOGs, as long as you give them, the woman will not menstruate at all. So that's what is desirous also. So now that is the medical management of endometriosis. I can give her an injection depomedroxyprogesterone acetate 150 milligrams once in 3 months. That is a high dose of progesterone, and that causes a pseudo pregnancy like state. Yes, remember I was telling her an option of getting pregnant? No, it's actually getting a state of a pregnancy. That is, I give her such high dose of progesterone just like she has in pregnancy. So what does progesterone do to the endometrium? Wherever there is endometrium, it gets secretory and remember, stabilized. So all the endometrium, wherever it is, because of the high dose of progesterone, the endometrium will get stabilized and it will get secretory. So the first month with this, she'll have very less bleeding. Next month, the progesterone is still there. It's going to act for 3 months. Next month, there will be much lesser bleeding. Third month, 1 or 2 glands will try to proliferate with the estrogens, but there is so much of progesterone that this progesterone will overwhelm the estrogen and stop any proliferation altogether. So there will be no proliferation. Wait a minute, when there is no proliferation of the endometrium in the uterus and there is no proliferation of the endometriotic deposits in the pelvis, yes, when there is no proliferation, we call it atrophy of the endometrium. So yes, in 3 to 4 months of therapy, the patient will have an atrophy of the endometrium. Or you can also give this patient something like a danazol tablet. Danazol is an androgen which has an anti-estrogenic action. Now this is even smarter. I was saying you give progesterones because progesterone act opposite to the actions of estrogen. What about danazol? Danazol inhibits the estrogens directly. Much faster action, much faster inhibition of estrogenic action. So it causes much faster atrophy. But yes, it also causes much faster hirsutism. Yes, after 8-9 months or even sometimes 1 year later, the patient may have severe hirsutes. She may also have virilization. Now, what's the difference between the hirsutism and the virilization? Yes, virilization are changes like the breast atrophy, hoarseness of voice, and clitomegaly, which are irreversible. Yes, they are irreversible. Very important to understand. So these changes, if they happen, the woman will have to live with them. What is hirsutism? This all of us know. The male pattern baldness and the facial hair and the acne on the face, acne on the body. This is what is hirsutism, yes? And the growth of the hair around the umbilicus is too much and the periareolar hair. This is what is known as hirsutism. But these are reversible things. What is virilization? Virilization are permanent changes. So if the breast gets atrophic, you cannot treat it by giving estrogens. The breast will stay atrophic. You will have to do some surgical, plastic surgery you might have to do for the breast size then. Then the hoarseness of voice. The first sign to stop treatment with danazol is hoarseness. Yes, the first sign to stop treatment with danazol is the hoarseness. And clitomegaly, the clitoris becomes hypertrophic because of the high androgens. And yes, you won't believe that I saw a patient once who was having danazol therapy for a very long time. She had a clitoris which was 2 centimeters. It actually looked like a small penis. So yes, these are permanent changes, which is known as virilization. Then yes, we can also give our friendly drug, which is known as the combined oral contraceptive pill. Now what do these OC pills do? They will make the cycle anovulatory, so the pain will be much less in menstruation. Also, when I give combined oral contraceptive pills, the amount of estrogen in the body is high or low. We discussed that the estrogen component is based on the principle of giving the least dose possible, which suppresses the FSH. So that's what is the combined pill. Low dose of estrogen suppresses the FSH. So the amount of estrogen in this woman with endometriosis is actually low when I give her OC pills. So that's why the rate of proliferation of endometriosis is much slower. It limits the endometriosis again. It's, if not a trophy. Then what about GnRH analogues? What are the GnRH analogues? Yes, you know them. The leuprolin and the naferlin and the gosserlin. So what are these drugs? They are analogues of the GnRH. What do you mean by analogues? Similar drugs or dissimilar drugs? Actually, analog means similar drugs and similar action. Wait a minute. Is that desired here? We discussed in the first class that the hypothalamus acts on the pituitary by the GnRH, and when the pituitary is acted upon by the gonadotropin releasing hormone, releases the FSH and releases the LH. But if I give something which is similar to the GnRH and that acts on the pituitary, I think that will be a disaster then. The same action on the pituitary will make more FSH and more LH, and the high FSH will make so many follicles that the woman will have high amount of estrogen, and the estrogen will cause the endometrium to proliferate at every place and cause so much of endometriosis that the woman will drown in her own endometriotic blood. No, I don't want that, isn't it? I know that the hypothalamus acts on the pituitary by the GnRH in a pulsatile manner. Yes, so this is normally pulsatile. So when I give GnRH analogues, I don't give them pulsatile, because if I give this also pulsatile, it will obviously stimulate. You're right, it will stimulate the pituitary. So I give this in a depot form, very important, in a depot form or also in a continuous form. In a depot or a continuous form, if I give, there is just too much of stimulation of the pituitary. You remember the GnRH pulse is 1 in 90 minutes? Yes, it's 1 in 90 minutes. At that pulse, the pituitary receptors have enough time to recover. These pituitary receptors have enough time to recover if it is once in 90 minutes stimulation. So stimulate, respond, and then stimulate and respond. But when I'm giving the GnRH analogues, I'm giving it in a depot form or in a continuous form. So there is so much of GnRH always acting on the pituitary. So there is so much of stimulation of the pituitary that the pituitary receptor has no time to recover from the stimulation. See, this pituitary receptor is a human receptor. It's not a machine, isn't it? It's a human protein. So this protein you stimulate, it responds. Then you stimulate again, it'll respond. So that is once in 90 minutes. That's what is normal. But now when I'm going to give GnRH analogues, I'm very smartly giving in a very high constant stimulation form. Either I give it in a continuous form daily, or I put a oil-based injection into the patient's bum and it is secreted throughout the day. So there is so much of stimulation of the pituitary, there is no recovery. It's like stimulate. So much of stimulation of the pituitary that the pituitary receptors have no time to recover and act to the next stimulation which is coming. So yes, the pituitary receptor needs time to recover. It's a human receptor. It's not a machine, like I said, isn't it? See, the analogy I give sometimes is like, if you want to go someplace and suppose you're riding a horse and you whip your horse, he runs 2 kilometers. Then you whip your horse again, he runs another 2 kilometers. Suppose you want to go 40 kilometers today, you take your whip and you make a calculation that if I hit him once, he goes 2 kilometers. Let me hit this horse 20 times now so that he'll run ultimately 40 kilometers. By that logic, you try to hit the horse. You hit the horse 20 times. Forget running 40 kilometers. The horse will just vault and he'll throw you off his back. So yes, this pituitary receptor is like that. That you do not let it recover, it cannot act. So yes, if the GnRH acts once in 90 minutes, it has enough time to recovery. But if you give it in a continuous form, then the pituitary receptor gets down regulated. The word we say is down regulated. So down regulation of the pituitary receptors or desensitization. These are all MCQs, okay? Down regulation or desensitization of the pituitary receptors. So now the pituitary will be sleeping. There will be no FSH, there is no LH because it's all down regulated. So when there is no FSH, there is no stimulation of the ovary, there is no follicular formation, there is no estrogen. And when there is no estrogen, wherever there are endometriotic glands, they become atrophic. Yes, this also causes atrophy. Yes. Now the crux of the discussion. So when I'm giving the depometroxyprogesterone acetate, there is atrophy. When I'm giving the danazol, there is atrophy. And when I'm giving the GnRH analogues, again there is atrophy. And when I'm giving the combined pill, there is limitation of the endometrial proliferation. So atrophy, limitation, and then again atrophy and atrophy. So what am I trying to do? Yes, what am I trying to do when I'm doing the medical management of endometriosis? Yes, I'm trying to create atrophy everywhere. Can you see this? Yes, I'm trying to stop the proliferation, stop the periods. That's what I'm trying to do. That's the punchline of the management by medical methods of endometriosis. Wherever there is endometrium, I atrophy the endometrium. So yes, it gets atrophied in all the deposits in the pouch, on the uterus, on the tube, on the ovary, and also inside the uterus. Obviously, inside the uterus also there will be atrophy. So yes, the woman will not bleed for so many months. As much as you give the GnRH analogues, as long as you give them, the woman will not menstruate at all. So that's what is desirous also. Now yes, I will stop the periods so that I allow the woman to have a healing for those months. Now the problem. We were discussing about a patient who was 25 years and she had a chocolate cyst and you removed it, surgical treatment was given. Then what you do? I give her next the medical management. For example, I give her GnRH analogues. So this is what the story I was trying to tell you in endometriosis. Now the patient is not very happy. She's saying, so you're giving me GnRH analogues and you said when I take it, I'm not going to have periods. So you're stopping my periods? I don't want to do that, sir. It's the sense of my completion. It's my physiology to have periods. I feel like a woman if I have periods. All right. I know. Just relax. I know it's a sense of your completion. It's an important part of any woman's physiology. But hello, when you have your physiology, you have such bad endometriosis, isn't it? So yes, I have to stop that physiological part of you so that you don't get endometriosis, because of which you're coming every month with so much of pain to the outpatient department. In fact, 7-8 days of the month, you're in the casualty with the pain and I'm giving you shots. So let me stop your period. You'll not have the painful episodes. And when I stop your periods, you will not have periods and you will not grow the endometriosis also. So you will heal and you will be better off and you can attend your work, you can go to your college, wherever. So now the patient is, okay doc, I understand that I'm 25 and you're going to give me GnRH. So how long are you going to give me GnRH? Well, my mode of action is very clear. I want to give you GnRH as long as you plan not to conceive. The day you decide to conceive, I will stop it. Sir, I'm going to get married at 28. It's 3 years from now. Fine. Take GnRH for 3 years. Go ahead and take it. 3 years, no periods? Yes, we already discussed. No periods, no endometriosis, you'll be better off. Go. Patient reluctantly agrees. And I've given her GnRH analogues 3 years. At 28, she comes and says, sir, I've got married. This gentleman is my husband. This is my marriage certificate. Now, please, can you stop the GnRH? Promise me that you will conceive fast. She says, okay, sir. The moment I start my periods after stopping this tablet, I'll try. So she's a very obedient patient now. She gets her periods, she tries, and in the first month she conceives. So tell me, how many months she will not have periods now? 9 months? Plus another 9-10 months or almost 1 year for lactation amenorrhea. Yes. Now she'll not get periods for 2 years. So 29 she conceives, until 31 she had no periods. By the time she was 31 and a half, she comes to me again. Sir, I got my periods and I was a case of endometriosis. You told me to have a pregnancy. Now I'm 31 and a half. What next? Get pregnant again. Yes. And she's like, oh, I just had a baby. It's all right. You can be having another one. Everybody likes 2 babies at least. She agrees. Second pregnancy, and now for another 2 years, she's bereft of the periods. So she's happy, she's got no endometriosis. She finally comes to me at 35, and now she says, Doc, I had 2 pregnancies. Now don't tell me to have another baby. Tell me what is next. Now you're 35, and you were a case of endometriosis, and I've actually not made you have periods for the last 10 years. From 25 onwards, I've not made you have periods. And I've given you treatment for 2 children. Okay? Maybe I can do a hysterectomy now? Bad answer. You can do hysterectomies when the women are beyond 45, 50. You cannot do hysterectomies for young women, especially because when you do the hysterectomy, it's not much treatment. The ovaries are making the stimulation by the estrogen and progesterone to all these deposits in the pouch of Douglas and in the peritoneum. So you have to cut off the ovaries also, because they are the ones which are making the estrogen, not the uterus. Uterus has given the nidus by retrograde menstruation. Now those nidus will still stay. They will still stay. You can take out the uterus, but the nidus will stay in the peritoneum. So yes, you will have to remove the ovary also. So now the gist of the discussion, that yes, she cannot have a hysterectomy at 35. She's already had all the children. So what was the third option? Yes, create a state where she is not having periods too much, and the periods are lesser in amount, and she is anovulatory. Yes, combined oral contraceptive pill. I tell her, you take the pill now. She's like, Doc, I have periods regular myself. Why should I take Ocipils? Because I want you to menstruate only very less. In fact, I want you to menstruate with less pain, so that now that you've had your family life complete, you have another 15 years of menstruation left. So let us give you periods which are less painful and having less amount, because endometriosis will settle only when you get into menopause. So now that's the punchline of management. That's the algorithm, that if it's a case of endometriosis, then yes, you do a surgical treatment, and then you do medical suppression, and after that she's either pregnant or she's on combined oral contraceptive pills. Yes, that's the algorithm of endometriosis. I'm sure it is not given like this in so many of your books, but this is the practical way which we manage, and this is what is asked in your exams. Then yes, that what is the benefit of not letting this woman have so much of menstruation? She'll not have so much of endometriosis, as simple as that. So yes, you can continue patients on Ocipils for a very long time. They are excellent treatments. They will at least limit the rate of proliferation of endometriosis. You know what? I don't give the OCPs the regular way it is given in the contraception requirement. We give it much smartly in endometriosis. You know what? I give the combined oral contraceptive pill, 21-day pill. I give her 4 packs. Yes, I give her 4 packs. Take them one by one. You finish 21, start the next pack. Don't give a gap of 7 days after the 21 days. So yes, 21. Start immediately when this 21 finishes. Another 21. And then another 21. And then another 21. So I give it for 84 days continuously. So when I give this for 84 days continuously and stop, the periods will start something like 90th day. Yes. So yes, if you give 4 packets continuously, she'll get periods only once in 90 days. That is once in 3 months. That's so nice. Lesser number of periods, and the amount of estrogen progesterone in Ocipils is more or less less. So the amount of menstrual blood formed is also less. The rate of disease progression is less, and the painful episodes are less. Wonderful treatment, these Ocipils. All right, these Ocipils are not bad treatment. All right, wonderful treatment. So yes, now I also told you that when we give GnRH and LOGs, I told you in this patient you give it for something like 3 years. Actually, the problem with GnRH is that if you give GnRH in LOGs more than 6 months, the osteoblastic action on the bone, osteoblastic bone action is estrogen dependent, and that will stop. But the osteoclastic action, this is independent of estrogens, that will continue. So that's the problem. There will be a net result is that this, suppose the femur, the bone matrix formation, the osteoblastic action is not going to happen. So the blastic action is not happening and the clastic action will continue. So the net result is an osteoporosis. The osteoporosis is the net result of a woman with GnRH if you give for more than 6 months. So yes, if you want to give, if GnRH in LOGs have to given for more than 6 months, then you must have something called the add-back regime. The add-back regime. So what is the add-back regime? Low dose estrogens. Yes, low dose estrogens or even raloxifene. Yes. So if you want to give GnRH LOGs for a longer time, see this, if you want to give for more than 6 months, then osteoporosis can happen. So I said I gave for 3 years. I've given women GnRH LOGs for much longer sometimes. But I will also start them on something called the low dose estrogens. Even raloxifene has known to help. What is raloxifene? So raloxifene is a selective estrogen receptor modulator. So that's what it is going to act like a estrogen at some places, and the same drug is going to act anti-estrogenic on some places. So on the bone it is estrogenic. That's why it is excellent for the bones for osteoporosis. We'll be discussing more about raloxifene when we discuss the hormone replacement therapy.